isolation ward, if you can remember, ward 36, and quarantine ward, ward 25, and isolation ICU, PICU, and microbiology services, and then the GMO office and the mortuary. They were the departments who were involved in this battle earlier on. So we had to sort of triage these people, make a diagnosis, and once the diagnosis made, there were so many places to be sent, IDH, you name it, Iranavilla, wherever. So we had to keep these patients for about maximally 24 to 36 hours, and then the problem was over for us. But what happened on April? Move in next slide. You want to go to the next slide? All right. April, we became a treatment center overnight. So what does that mean? What was the meaning of that was we had to sort of bring a lot of facilities to keep these patients, because there were no places to send these diagnosed patients from teaching hospital Karapitiya. So we had to, the prevailing services like triage, ETU, red center, blah, 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 they were not able to cope up with the increased workload. And not only that, there were no places to take these patients from IDH and wherever you name it. Everybody were refusing to take our patients. So we ourselves had to sort of keep these patients, so that we had to make arrangements for level 1 care. We had to take ward 46 and level 2 care, ward 35, ward 36. And then we had to, there were patients who became unstable, and there were patients who were unstable even on admission. So we had to make one of our ICUs as a COVID ICU. There were so many requests from us for ECMO, being the only place for ECMO in Sri Lanka. And then not only that, we had to increase the facility for pediatric patients in the hospital. And then a couple of ICCs were given for Karapitiya to manage, like Maliban, Walahanduwa, Abaradu and all. And not only that, we had to operate the RAT center at the OPD. So what do we need as TH Karapitiya to sort of give this much of, cater this much of workload? We obviously needed more manpower for that. And not only the manpower, we needed people with knowledge, trained and good attitudes. And of course, we needed more equipments and facilities, which was basically the administrator's work. But I'm happy to say a lot of consultants and other people have contributed, bringing a lot of donations. So as consultants, we thought it's our duty to make the people who are joining with the COVID battle knowledgeable and trained, and give them some orientation. That's why we bring this to help staff to gain scientific knowledge and training, thinking that would help us to win over COVID. So that is how this program was conceptualized. And as I said, we conducted about 12. Now this is 13 program. I think Aruna has lined up a lot of important lectures here. So with all the very best for we know the pediatric team have been doing a fantastic job from the beginning. And we initially ran this program. I wanted to do it physically, because that time we had to make a team. That is why we decided on having physical meetings. But I know the pediatric team is a super team. So I believe the Zoom platform is suitable for them. So I wish all the very best for Aruna and the team, and respecting your all the efforts to save lives in kids. Okay, thank you very much.
Thank you, Ganaka. I would like to thank again the Ganaka to Arosha Vikram and Arosha Disanayak, as well as Jana Yenage, for arranging this sort of lecture workshops for our staff members to increase their awareness and knowledge, as well as to boost up their morale looking after sick COVID patients. I think I'm not very sure about other hospitals. I would say that this would be the. I haven't heard from my other colleagues from other parts in the country that this sort of program is happening in any other hospital. So I would like to congratulate them again for organizing these sort of things in our hospital. So moving on to my lecture, very short lecture. It's on the pediatric perspective. Right. So just a little bit about the pediatric perspective of this illness. We'll move on. So this is what I'm going to briefly discuss. Just introduce what's COVID-19 in children, a little bit about pathophysiology of this disease, and factors proposed to explain the difference in severity of COVID in adults and children. Now, I'd like to stress the fact that it is proposed factors and nobody knows exactly why it is. So move on with the things. Children of all ages have a risk of getting COVID. Now that's very well known, but there's slight differences between COVID in children and in adults. So the average incubation period in COVID-19 in children is about 6.5 days, which is a bit longer than which is 5.4 days in adults. So adults have a shorter incubation period compared to children. There's no significant difference in gender in pediatric COVID patients. And I would say 95% of the cases, this is from the data, most of the figures that I mentioned here are from the WHO website, because there's lots of information in the internet. So to get some sort of reliable data is from WHO. So this data is from WHO recent website. 95% of the cases are either asymptomatic or diagnosed with mild to moderate symptoms. So we are lucky to have most of our patients who does not have any symptoms, or most of them will have like a cough and cold, and that's all. Only 5% had developed severe complications, compared to this amount is 20% in adult patients. So that is why Ganaka and the team has more work than us compared in this hospital, as well as I think it's the worldwide trend. So who are the children who are at a higher risk of getting severe COVID infection? Obviously, immunocompromised children due to either acquired or congenital immunocompromised conditions. We all know about these things. And pulmonary pathology like asthma or whatever other pulmonary pathologies, congenital abnormalities, anything. Of course, infants less than 3 months, or they have a high risk. Patients with underlying diseases such as diabetes or whatever other conditions, chronic illnesses like SLE or whatever, they have a higher risk. Thalassemia, these are the high-risk people that we have with chronic illnesses. And I would like to say immunocompromised mean children with who are under treatment for cancer therapy and things like that also goes under the immunocompromised section. And we have been unlucky to have some of these kids dying at LRH from Maharakama. Of course, the number one from our side here is the obesity. Obese children have a very high risk of developing complications. So you should be careful in a child who's got COVID and obesity. Now, recent virologic data indicate that viral load in the asymptomatic patient was not significantly different from that of a symptomatic patient. What does this mean? Whether you have the disease or not, the symptoms or not, children are having a very high viral load compared to adults, where they have high viral load when they have symptoms. A very good example is we had two patients in our ward just yesterday and day before, who one was planning to transfer to ICU, and the other one we were planning to send for a surgery. Both had PCRs done as a prerequisite, not because they were having any symptoms. Both of them came positive with a CT value of less than 30. So this is what it means. Whether they have symptoms or not, if they're positive, they have a high viral load. which means we have a lot of trouble in our ward because we do not know which one has symptoms, which one doesn't have symptoms. And if they are positive, there's a high chance the rest of the ward members as well as the ward patients might be contaminated. So we have to be very careful. A little bit about the clinical presentation. The clinical manifestations of pediatric patients are mostly non-specific, as I mentioned earlier. And common symptoms include fever, cough, abdominal pain, myalgia, and fatigue, which the next speaker will talk in detail. Another important fact is that the median duration of fever in children is about 3 days, whereas in adults it is more than that. So what happens to children when they get COVID is commonly they have high fever in the first day, a bit of less fever in the second day. By third day, they're usually having a bit of cold and their fever has settled. So we can probably reassure the parents if you get a call that your child is having fever and COVID, probably positive for COVID, or the parents having COVID. You can reassure that you can wait for about 3 days with some paracetamol and see if things have settled. Most of them would settle, I would say 95%. And if it doesn't settle by third day, I would advise them to come to the hospital and get medical advice. A little bit about pathophysiology. Now, this is a very busy slide. I have divided it into two. Now, when the virus comes and attaches to the respiratory epithelium in the nasopharynx, it attaches to the ACE2 receptors. Now, that is where the virus attaches in the epithelial cells. What happens after attachment is the virus replication occurs and local propagation occurs with limited immune response. Now, in the nasopharynx, there's limited immune response. And about, I would say 95% of the children, they will, this limited immune response will stop it further escalating, and they will get better within the next 10 to 14 days. Now this 80% is for adult, this chart is for an adult chart. Now about 5% of the children, the involvement of the conductive airways and the upper respiratory tract, and they will migrate into the lower respiratory tract as well. When you go down, when it goes down, the virus goes down, the invasion and infection of the type 2 pulmonary alveolar epithelial cells via ACE2 inhibitors will happen. We all know that from there downwards, there are two cascades. One is the viral replication and release of viral particles with resulting apoptosis of the host cell. Now in the lung tissue, the viral replication will happen and the tissue damage will occur. Continuing viral replication and the infection of the adjacent healthy alveolar epithelial cells with loss of both type 1 and type 2 pneumocytes will ultimately end up with diffuse cellular damage with resulting acute respiratory distress syndrome, which we all know as ARDS or ARDS. On the other side, we all have heard the term cytokine storm in COVID. This is the other part with the attachment of this virus to the ACE2 receptors in the lungs. That will cause a severe inflammatory cascade, and the release of interleukins, tumor necrosis factor will happen, and that will cause chemo attraction of the neutrophil CD4 cells and CD8 cells and cause a inflammatory cascade. And this causes sequestration of inflammatory cells in the lung tissue with CD8 mediated cytotoxicity as well as lung injury. Now, this is a host defense and attempt of viral clearance, and it is an exaggerated response, and that will also lead to diffuse alveolar damage and results in ARDS. Now, both these pathways will ultimately lead into ARDS. Having said that, I have mentioned that only 5% of children will lead into this sort of areas. Although you see this as a very simple thing, on top of this, you get a lot of secondary bacterial infections as well as other comorbidities also comes into play, like obesity, diabetes, and other things. So this is just the basic pathophysiology, what happens when a COVID virus enters into your body. Just the pulmonary pathology. Now, why is COVID is less severe in children? Now, as I mentioned in the first slide or in the topic, that this is hypothetical ones, and this is data from Archives of Disease in Childhood, a recent one from 2021. And these are the hypothetical things that they have mentioned. Factors that reduces the risk or makes less severe COVID in children. One is differences in innate and adaptive immunity. You know that this is the first defense mechanism in the body. So it is very efficient compared to adults in children. So that is one reason. More frequent recurrent or concurrent infection. You all know that respiratory symptoms are much more common in children compared to adults. Difference in the microbiota. Now, children have different microbiota compared to adults, so that also has a defense mechanism. Higher levels of melatonin. Now, melatonin is anti-inflammatory agent, as well as it prevents inflammatory cascade. So that is in higher levels in children, and that also helps to prevent this inflammatory cascade. Protective off-target effects of live vaccine. Now, we'd have heard that some people were telling that BCG would have given protection for Asian children. That is what is meant here. Protective effects of off-target effects of live vaccines. Some of these live vaccines, they believe that not only for that particular disease, that gives some immunity towards other illnesses as well. And though intensity of exposure to COVID virus. This is because the children usually do not go outside. If they get it, mainly they are from their parents, not like the adults. Now in adults, why are they having a high risk? Because age-related increase in endothelial damage, you know that smoking and other things causes endothelial damage, and that increases the risk. Higher density and increased affinity of angiotensin converting enzymes. They have a higher density of ACE2 inhibiting ACE2 receptors in their respiratory tract, and higher prevalence of comorbidities. Of course, that's you can understand that they have lots of other comorbidities compared to children, and they probably have pre-existing immunity to coronavirus. So that immune reaction is much more higher in adults compared to children. And of course, they think that lower levels of vitamin D in adults will also as a risk, as they have taken it as a risk, because vitamin D also acts as an anti-inflammatory action as well. So these are the things that have increased the risk of COVID, or the increases the severity of COVID in adults, whereas the previous slide I explained why children has a higher risk, or their severity is less with COVID. I think we have come to the conclusion. So I will invite Dr. Parami Gunasekara to give a speech on how you manage COVID at the ETU setup in our hospital. Thank you. Over to you, Parami.
Thank you very much, Aruna. And good morning to you all. You are welcome to the WinCovid program. Within next 10 minutes, let's talk about how ETU contribute for COVID battle, especially for the children, when concerned about the children. So I'm going to outline the admission policy of the ETU and what are the functions of the main triage, and functions of room number 100 and 300, and how stabilization of unstable patients, especially COVID patients, and to whom we are doing pre-procedural RAT service, and how we are manage out of hospital cardiac arrest, and what are we going to do on admission dates. As you all know, this is the reception of ETU, the front desk. This is a nursing triage actually, and 2 nurses are there with full PPE. Whenever we receive the patient, that the nurses, they are checking all the vitals of this patient, especially they are checking saturation, pulse rate, blood pressure, and respiratory rate and conscious level. As you all know, we are having triage sheet. According to the vital signs, they are categorizing the patient. So that our ETU admission policy, irrespective of COVID status or COVID related history, all unstable patients will end up with will admit to the ETU. So after doing triage, if the patient is unstable, that is category 1 and 2. So irrespective of COVID status, we admit the patient to the ETU. If the patient is stable, that means the patient can send to the ward properly, and category 3 and 4 patients will direct to the MO, OPD, that doctor who is doing the admissions. But if this patient is having some suspicious about the COVID, then they have to go to the room number 100. So in our ETU, we are having a COVID cubicle. It contains 5 beds. Actually, you can see the entrance of that COVID cubicle. We are having a separate staff to work inside the COVID cubicle. So all unstable patients with COVID or suspicious ones will admit to the COVID cubicle for emergency management, and initial stabilization of ABC and further management was done at the COVID cubicle. As after stabilizing the patient, we are sending them to COVID wards to that level 2 or level 3 according to the status of the patient. If that patient, if we are suspecting this patient is if we are suspecting the patient is having COVID, then probably we are doing RAT. Not only the patient, we have to do RAT of the mother or guardian, because this one is the one who is looking after the baby while in the ward after admission. You all know this is the room number 100. You can see in front of the ETU, and one doctor and nurse is doing that. So what are the duties of room number 100? We are allocating a BHT for each and every patient. They are taking a history, and there we are doing only visual triage. And the medical officer is doing a general assessment of the sick child, and they are checking the saturation, pulse rate, as well as blood pressure. If there are suspected patients and mothers, then they will go to the room number 300 for rapid antigen test. So for the stable patients, stable COVID positive patients will send to the level 1 care, probably ward 68. But even though they are stable, but if they are having some underlying medical problems such as immune deficiency, lung disease, congenital heart disease, or some other pathology, or especially neonates, we prefer to send them to the level 2 rather than sending level 1. This is room number 300 where they are doing RAT. That one medical officer and nurse is there to do that. And then let's talk about pre-procedural RAT. For all surgical people, all surgical babies, and trauma and those who are critically ill, we have to do that before sending them to the theaters and ICUs. And now you can see a picture. This is a first bed of the COVID cubicle. We are doing out of hospital cardiac arrest there. This is in front of the triage. Whenever we receive the out of hospital cardiac arrest patient, the triage nurse will ring the 3 bells. There are 3 bell system. So immediately the patient will sent to the COVID cubicle, and most senior doctor, including consultant, has to rush to the triage desk to take a history from the parents or guardians to decide whether we are continuing the resuscitation or not. If patient recovered, then probably we have to do a RAT, and then we have to find out an ICU bed for a COVID patient. Probably in ward 1, we are having 1 bed for a critically ill COVID patients. If that bed is occupied, probably we have to trans out. If patient is not recovered, then we have to do death confirmation. We have to order inquest. And at the same time, we have to do a PCR of the dead body and proper disposal of the dead body to a body bags. And at the same time, sometimes we are receiving dead bodies from the community, especially the babies with a lot of congenital problems that mothers are taking these dead babies. So in that case, we have to do death confirmation, taking PCR from the body, and also we have to communicate with the relevant authorities like police and GMOA office. So these are the things that we are doing in ETU to win COVID battle. Actually, I think you are having some idea about that. So I would like to give my seat to Dr. Upeksha Liyanage to continue the other lecture. Thank you very much.
Good morning, everybody. For next lecture, I'll invite Dr. Upeksha Liyanage, consultant pediatrician from Teaching Hospital Karapitiya. Over to Dr. Upeksha.
Thank you, Ganganath. Good morning, and we'll do this is level 1 and level 2 care. So when we take our patients COVID positive, it could be either RAT or PCR. They will be managed in 3 levels: level 1, level 2, and level 3. So level 1, it could be home-based care or intermediate care center care, or level 2 should be in a hospital, and level 3 hospital. When you take the care pathway of these patients, we have 3 categories of patients. So children in the community and children present into the hospital and children admitted for routine procedure or investigation. When we take children in community, so they will be triaged by MOH. Then the children present into the hospital, they will be triaged by MOPD or ETU. And then there's another group admitted to the routine procedures and investigations. Then they will be, when they are positive with routine screening, in our hospital setup, we have Ward 68 as well for these children. So then we have to decide about eligibility for home-based management. And if they are eligible for home-based management, so then we can send them for the level 1 care. We call it patient home isolation and management system. If they are not suitable for home-based management, then we can send them to level 1 ICC care. Or the otherwise, that if they need admission to hospital for monitoring and care, so they will be managed at level 2 or level 3 care. In our hospital, we have for level 1 ICC, we have Melbourne Hospital, and level 2 and 3, we have Ward 36 and ICUs. So eligibility criteria for home-based management, the children should be between 2 and 14 years, and they should be asymptomatic or mild symptoms like mild cough or pharyngitis, but they are clinically stable. Fever-free, especially the children who are in the hospital, we'll send for the home-based care when they are fever-free. But children in the community, if fever less than 38 degrees centigrade or fever less than 3 days, we can send them for home-based care. And feeding and activity satisfactory, no shortness of breath, tachypnea or rapidly worsening symptoms, and saturation more than 96% in air. No significant comorbidities like chronic lung disease, uncontrolled asthma, chronic kidney or liver disease, cerebrovascular disease, obesity, significant genetic metabolic disease, diabetes mellitus, hemodynamically significant heart disease or hypertension, primary immune deficiency, acquired immunosuppression, or any other significant illness, so that we are not going to send them for the home-based care. Safe household, and parent or caregiver should always be with the child, and they should have ventilated room with adequate facilities for home isolation and adequate communication facilities. So home-based care management, so like paracetamol, but no NSAIDs or steroids, they need adequate rest, good nutrition, hydration and hygiene, continue long-term medications if they are on those, and that our PHIMS team, that is that mainly the MOH of the area, so they have a system like that, so they will advise the parents. Parents will be given an information leaflet, then daily monitoring over the phone will be done. And if there's any red flag signs, I'm going to talk about those later. So they have to inform MOH or relevant PHI, or there are two emergency numbers, emergency center 1390 or 1990 ambulance. And advise parents to record the temperature, monitor for respiratory difficulties, and saturation if there's pulse oximeter available, or if there's any, just they have to look for feeding difficulties, sleepiness, lethargy, and good urine output. So if everything is all right, then we can discharge them after 14 days. But these are the red flag signs for all the groups. Fever more than 38 degrees centigrade, or fever more than 3 days, or recurring of or reappearing of fever, significant abdominal pain, significant vomiting or diarrhea, poor feeding, significantly reduced urine output, sleepiness, irritability, poor activity. Respiratory difficulty, they have shortness of breath or tachypnea, especially for children between 2 to 5 years, if respiratory rate more than 40, and or above 5 years, if respiratory rate more than 30. So that's a red flag sign. New uncontrolled cough, if the saturation is less than 96% in air, cold peripheries, or worsening of symptoms. So if any of these red flag signs are there, they need immediate institutional care. So level 1 ICC care, like our Melbourne Hospital, so that mainly for asymptomatic children less than 2 years, sometimes social circumstances, or continuation of level 2 care, for an example, continuation of IV antibiotics, or asymptomatic children with comorbidities. So level 1 care management at ICC, management under direct medical supervision. So there is a medical team, pediatrician, medical officers and nursing officers and other staff. The center should be well equipped with patient monitoring facility, example pulse oximeters, medication to manage common diseases, emergency drugs and equipment, and ambulance facility. Monitoring all the patients should be assessed 2 to 3 times a day, respiratory rate, heart rate, and saturation. Look for development of any new symptoms, worsening of existing symptoms, or respiratory symptoms. If there's any disease progression or any red flag signs, then they need hospital care. It could be level 2 or 3. Then the level 2 care, that is for the symptomatic children. So it could be mild to moderate respiratory symptoms at any age, or children with red flag signs but not needing level 3 care, and children with other acute or chronic diseases who require hospital care and observation. But these children may be asymptomatic or mildly symptomatic with COVID-19 infection. So acute illnesses like meningitis, acute gastroenteritis with dehydration, sepsis, or children with convulsions, and there's a long list of children. And chronic illness with acute deterioration of disease like cyanotic heart disease, chronic lung disease, or any other comorbidities. So level 2 management. So these children need close monitoring, and so they might need oxygen via face mask or nasal prone oxygen, IV fluids. They might need antibiotics or any anti-epileptic drugs. For an example, sometimes thalassaemic patient, blood transfusion, or immune deficient child might need for their immunoglobulin transfusion. We can admit the child there. This is under senior supervision. And if there's any deterioration, we have to send the child to the level 3 care. So that is about level 1 and level 2 care. Thank you.
Thank you very much. I would like, thank you very much, Madam. I would like to invite Dr. Nalin Kitulwatta, consultant intensivist from Paediatric Hospital, Colombo, to talk about level 3 care. Over to Dr. Nalin.
Thank you very much, Ganganath, for the kind introduction, invitation. So I'm trying to do this, the management of COVID-19 in children, level 3 care, in next 10 minutes. So, we know that it's a new disease, just 1 year. So evidence is changing rapidly, and you need to update always, because just because we are talking about this today doesn't mean that you know everything about COVID management now. And the decision should be taken depending on the most recent evidence. And this is the reality. This was published in May this year. From COVID-19, all patients, only 14% are children. And if you think about the hospitalization, again, 1.3 to 3.1 are children. And if you take about the COVID-19 children, only 0.1% to 1.9% needed hospitalization. So that shows the gravity or the reality of the pediatrics COVID-19. Having said that, not like the first and second waves, now we are seeing more and more symptomatic children. So because of the large number of patients. In our ICU, this is the data. So total number, we have managed about 93 patients up to yesterday. 45 patients are missing. Infants 13, patient with comorbidities again 13. If you think about the deaths, there are 18 deaths. That means if you think about out of the all the admissions, it's 19%. And comorbidities, the children with comorbidities are having a higher chance of death in ICU, 61%. And if you are previously well child, dying in ICU, it's about 12%. So when you're assessing the severity of the disease, so we have discussed these things, we should know about mild to moderate disease, severe disease, or the critical disease. Mild to moderate means there's no new requirement of supplemental oxygen. So far we have discussed mild disease is no tachypnea, no respiratory difficulty, no other features of pneumonia. Moderate disease, we have some features of pneumonia, but not severe pneumonia. Saturation is less than 90, less than it's about 94 in room air. The severe disease means new requirement for supplemental oxygen in severe pneumonia. Critical disease means need to invasive or non-invasive mechanical ventilation, sepsis, and multi-organ failure. So severe pneumonia means saturation is less than 90% in room air. Cyanosis, grunting, severe chest distraction, lethargy, seizures, hemodynamic instability, and radiographic infiltrates involving more than 50% of the multilobar infiltrates. So you can see that how bad the X-ray is. So we call it critical disease when you're having this type of pneumonia, the severe disease plus something like ARDS, circulatory shock, multi-organ dysfunction, acute thrombosis, and MIS-C. MIS-C will be deal with another lecture. So these are the risk factors for severe disease. So this is very important because when you are managing a COVID patient, if they are in this category, you have to think about severe disease and level 3 care in these patients. So if the child is less than 1 year, high chance. Obese, diabetes mellitus, chronic lung disease, chronic kidney or liver disease, complex medical conditions, congenital heart diseases, hemodynamically significant, and immunocompromised, long-term immune suppressants, or HIV. So if the patient is in this category, be more vigilant, and they may need level 3 care early. Right. So what about the level 3 care, management of severe and critical disease? The mainstay is a supportive, because we know it's a viral infection. There's no specific treatment. That doesn't mean that you cannot treat. So mainstay is the supportive. So we have to respiratory support. We have to use fluid and electrolyte support, empiric antibiotics, because at this level, they are more prone to get secondary infections because the immune suppression and the low white cell count and so on. And thromboprophylaxis, and we have to monitor about the cytokine release syndrome. So blood pressure, saturation, and biomarkers, you have to monitor LDH, D-dimers, ferritin, and CRP, because there's higher chance of developing this type of cytokine release syndromes, including MIS-C and HLH. So in this, at this level, you need some investigation. As I mentioned, you need full blood count, CRP, liver function, renal function, D-dimers, blood gas, serum lactate, and you need X-ray and the ECG, and echo, troponin I, LDH, serum ferritin, and you may be repeating after 24 to 48 hours as per the clinical condition, because if the child is not improving, just because they are normal in day 1 doesn't mean anything. So you have to repeat this investigation and see. Right. So mainstay is giving oxygen. So that's the key in the management of critical ill or the level 3 care. So these are the indications. So if the saturation is below 90% in normal child, below 91% in a neonate, below 70% in cyanotic heart disease generally. So this is the basic indication, and you have to escalate as needed. So for that, you should know about the oxygen delivery devices. So we are starting with nasal phones. I know most of you are knowing about nasal phones, and your target saturation is 92, not 100, and titrate oxygen flow with saturation. The saturation is not improving, so you have to increase the flow. If the saturation is better than 92, and come down with oxygen, because oxygen also now we are having some problem with oxygen, so don't waste oxygen. And after 2 hours, if the child is not improving, you have to escalate. Escalate means you have to change the device. Right? No point using the same device. So this is the escalation pathway. So starting with nasal prongs, then face mask, venturi mask, non-rebreather mask, and at the end, high flow nasal prongs. So nasal prongs, everybody knows. So a little bit about non-rebreather mask. So this is it. So here we are using oxygen reservoir bag. So this is the oxygen reservoir bag. There are one-way valve systems. So basically, so this from this reservoir bag, it can go this way only. The exhale air cannot go to the reservoir bag. At the same time, when the patient is expirating, so that exhale air can go out from this mask, but when the patient is inspirating, the air cannot go in to this mask. So one-way valve systems are there. So it prevents exhale gases mixing with fresh gas flow. Valve on side ports of the mask which prevent entrainment. Valve on side port of the mask which prevent entrainment of room air into the mask can provide higher concentration of FiO2, like 50 to 95%. The important thing is, before applying this, the reservoir bag needs to be inflated prior to placing on the patient face. So that's very useful in giving oxygen. Then about the venturi mask. Venturi mask uses the Bernoulli principle. So there are so many colors with these valves are there. So what happens? It uses the Bernoulli principle. Entrain room air when pure oxygen is delivered through a small orifice. So you are sending oxygen through this the small orifice. There are some holes here. So when the oxygen is coming, so air will entrain through these small orifices, and at the end, depending on the flow of the oxygen, we can decide the FiO2, the saturation. You can see if you are selecting the blue valve, 2 to 4 liters per minute, you can provide 24% FiO2. If it's a green valve, 12 to 15 liters per minute, you can go up to a 60% FiO2. So that's the importance of knowing this. Venturi mask, again, it's a way of giving predictable oxygen. Then the important message about these oxygen delivery devices, there is a minimum flow. Now look at this. Now nasal prongs, the minimum flow is 1 liter per minute. This is not per kg, this is 1 liter per minute. So neonate, less than 2, 1, 2 to 4, more than 4. It should be 1. So when you're using nasal prongs, no point using less than 1 liter per minute. Sometimes you're using about 0.5 liter. So that's useless. So the maximum flow also there. In neonates, it's 1 liter. Less than 2 years, 2 liters. 2 to 4 years, it's 4 liters. More than 4 years, 5 liters. Likewise. If you're using the face mask, the minimum should be 5. Maximum is 10. Venturi mask, again, it's depending on the color of the venturi valve. Non-rebreather mask is 10 liters per minute. Maximum is 15. And high flow nasal prongs, this is very important. So we are using high flow nasal prongs to prevent intubation. So if you want to prevent intubation, so what they say is the minimum flow should be 2 liters per kg per minute. This is the only kg. And all the others are just liters per minute. Here, 2 liters per kg per minute. That means if the child is 10 kilos, we have used 20 liters per minute. So that should be very clear. So you can give 100% FiO2. So this is the minimum, this is the maximum. So then this concept also very important. Now recently we came across this. Put a surgical mask on patient. So we can keep a simple surgical mask, surgical face mask on patient over nasal prongs and under any type of oxygen surface mask. So we can just put this the hyponasal prongs oxygen, and you are putting this simple surgical face mask on top of that. This procedure will do 2 things. One thing is it reduces the viral spread to staff and other patients. That is very important when you are giving oxygen, because they consider as a the aerosol dispersing procedures. So it's very important to prevent the spread, and it shows a CPAP effect also. Little bit about this. So this is the study they have done. This is on high flow nasal prawns. You can see without mask, with mask. This is low flow nasal cannula without mask, with mask. So this is without any therapy. So without mask, with mask. So you can see if you are using all these devices without mask, this is the exhale air dispersion. So how far that it can go if you are using the high flow. And just by putting a simple surgical face mask, all are similar. So basically, the exhale air dispersion has minimized by just putting a simple surgical mask over the patient. And what about the CPAP? So this is the study on that. You can see this is the PaO2, this is saturation, this is PF ratio, this is PaCO2. So all the parameters have improved with such simple surgical mask on top of the high flow. And when you're comparing with face mask to without face mask. So all the parameters are improved. So respiratory parameters is high flow nasal prawns alone and high flow nasal prawns plus surgical mask, improvement in all variables. So in summary, so this is very useful whenever you're using oxygen. Just put a simple face the surgical mask on top of that. So that will reduce the viral spread, and it will affect the CPAP effect, so that the oxygenation parameters will improve. And a little bit about high flow nasal prawns versus ventilation. Again, now the clear evidence is there that high flow nasal prawns is better than ventilation. You can say ventilation-free days are more, invasive care length of stay is less, in hospital mortality is less when you're using high flow nasal prawns. Because I'm stressing this because initially, when we manage initial part of the COVID, what they say is just to prevent the spread to the healthcare workers as soon as possible, intubate the children. So, but now the evidence is changing. So we try not to intubate, not to ventilate, and more high flow nasal prawns. So the message is you should use high flow nasal prawns if you want to get the survival rate more. And these are the ventilation clinical practice guidelines in adults with COVID-19, published by the European Society of Intensive Care Medicine and Society of Critical Care Medicine last year. So start oxygen saturation is less than 90, target 94 to 96. Conventional therapy, if fails, go for high flow nasal prawns. High flow nasal prawns is better than NIV. If you don't have high flow nasal prawns, go for NIV. And close monitoring is very important, and early intubation in a control setting if worsening. So early the close monitoring is to detect the patients who are deteriorating. So this is not a time to do the emergency intubation, because then you are exposing everybody and including yourself to the virus. So it should be a very controlled and elective type of intubation early if the deterioration is there. So oxygen therapy, the summary is this: start with nasal prawns, escalate depending on the condition. If there's a respiratory distress, go for high flow nasal prawns early, because high flow nasal prawns will give the CPAP effect. So that is better than giving any other oxygen delivery device. And target saturation is 94 to 96. And this is also very important. De-escalate depending on condition. When the child is improving, no point continuing oxygenation, because oxygen again, there's some problem with oxygen, so you should not waste. So de-escalate depending on the condition. Close monitoring is very, very important. And if there's any deterioration, early control intubation. So you don't have to wait for the last moment. But this is also very important concept, de-escalation. When you are de-escalating, don't use less than minimum oxygen flow for each device. So no point using high flow with less than 2 liters per kg per minute. No point using nasal prawns below the 1 liter per minute. So de-escalation, when the child is on high flow, you can go to non-repeat the mask, then it's better. Then go to venturi mask, even better, face mask, nasal mask. So gradually, one by one, we can come to this side. So I'm not saying always go to this flow. high flow nasal polyps. If the child is much better, directly you can go to the nasal polyps rather than go through all these things. The important thing is don't use less than minimum flow. So when the child is on high flow, just because the child is improving, don't give 1 liter per 80 per minute. In non-rebreather mask, when the child is improving, don't give less than 10 liters per 10 liters per minute. So it should be the minimum. So you can change the device when you're de-escalating without giving less than minimum flow. Right. So then this is the final message that I have to tell about the level 3 care. So this is our ICU. This is how we are managing our patients. So always one-to-one care, one nurse bedside always. All the needed procedures, there are aerosol generation procedures, nebulization, micronasal pons, intubation, non-invasive ventilation, high frequency oscillation, ICD insertion, PD, resuscitation. Basically, care is similar to any other child, but with full BP. So we are managing all the patients the same way that we are managing the other patient, but with full BP. The message is none of the staff members got the infection from the patients. Don't worry. You have to be very careful. You can use the full PP. You are doing procedures, all the aerosol-generated procedures with full PP. You will not get the disease. So that's the message that you have to get. So thank you very much.
Thank you very much, sir. Thank you very much for a nice and brief presentation. It is very informative, and it is the last message that is we have to do everything with full PPP. Then that is the main message that we can give. And thank you very much, sir. Next presentation, I would like to invite Dr. Imalka, consultant pediatrician from the Regional Hospital Karapitiya. Yeah, we can see the screen, but can you?
Hello.
Can hear? Yeah.
Right. Okay. Sorry. So I'm going to discuss about multi-system inflammatory syndrome in children temporarily associated with COVID, MIS-C. So in UK, this is labeled as PIMS-TM. It's a similar other term, but WHO has endorsed this term. So I'll be mainly talking about the introduction of the condition as well as the case definition and the clinical manifestations, and as well as a little bit of the management of MIS-C. So it's actually rising trend in children with or without COVID-19 status. So sometimes there are cases where we don't find COVID-19 positivity as well. So the exact mechanism and pathophysiology is not well understood, but lots of research are going on at the moment in all over the world to see the pathophysiology or understanding the pathophysiology of this condition. Possibly, this is something to do with dysregulated immune response leading to massive cytokine storms like. So similar things happens in Kawasaki disease, macrophage activation syndrome, hemophagocytic lymphohistiocytosis like conditions. So the important is this is a life-threatening condition, and patients might need sometimes intensive care admissions as well. So the basics of MIS-C is you can divide it into mainly 3 components depending on the severity of the illness. So the first or the least problematic entity is called febrile inflammatory states, where children may present with persistent fever and lots of vague symptoms. You can see most of these symptoms even in dengue fever, or sometimes in leptospirosis or even in typhus. But inflammatory markers may be elevated, but no multi-system involvement features in the first category. So the second category is almost always similar to Kawasaki disease, but there are some differences. So this is somewhat intermediately danger category. So majority of them will fix into the criteria of the Kawasaki disease, and but they do not have any features of shock or any multi-system involvement in the sense of severe multi-system involvement. And the severe MSC is the worst scenario where you have elevated inflammatory markers with multi-system involvement, and the cardinal feature here is the myocardial involvement with features of shock. So sometimes we all can come to the diagnosis of severe MSC because the picture is very straightforward, but sometimes the febrile inflammatory status, sometimes we might miss. But having said that, this is a benign condition when it comes to the first version of it. So if I talk about the Kawasaki disease, this is well known to all of us. So you should have at least 4 out of 5 criteria in the presence of fever more than 5 days. So the conjunctival infections, mucosal changes, cervical lymphadenopathy, any form of rash and changes in the extremities. So in the presence of these 4 out of 5 plus fever more than 5 days, you can diagnose Kawasaki disease. So depending on the timing of the illness, sometimes you might see different patterns in the full blood count, like elevated platelet count, neutrophil leukocytosis, high ESR, CRP pattern. And usually the cardiac involvement is seen from second week onwards. So then the question is, how are we going to differentiate type 2 MIS-C from Kawasaki disease? This is a very good comparison. If you want to differentiate MIS-C from Kawasaki disease, especially the type 2 MIS-C, so MIS-C happens in all over the world, probably around 10, 11-year-old children, but there are exceptions. Kawasaki disease is mainly confined to infants and toddlers like that age. So Asians, being an Asian population, so we do have higher risk of Kawasaki disease compared to MIS-C genetically. And the abdominal symptoms are more common in MIS-C compared to Kawasaki disease. And the myocardial dysfunction and myocarditis, so the are more common in MIS-C, whereas in Kawasaki it's mainly the coronary artery abnormalities. So the renal involvement is common in MIS-C, which is rare in Kawasaki disease. So the cardiac involvement like troponin positivity is common in MIS-C, but not that common in Kawasaki disease. Ferritin, triglyceride, CRPs are elevated in MIS-C. These are elevated even in Kawasaki disease, but not that severe. This is very important, the platelet count. So in MIS-C, it is more towards low or towards a normal side, but marked thrombocytosis will be there in Kawasaki. But having said that, there are children with Kawasaki disease who have got even normal platelet values also. So the lymphopenia is a marked feature in MIS-C compared to Kawasaki disease. And the association of COVID-19 infection may be there in MIS-C. Kawasaki, it has not been clearly mentioned. But nowadays the problem is we do have COVID antibodies positivity in number of other children with number of other diseases as well. So sometimes that is not that easy to differentiate at the beginning which one we are dealing with. So then how are we going to diagnose MIS-C? So we need to have a suspicion, then we need to try to fix into the diagnostic criteria. So children and adolescents, I'm talking about the WHO guideline here. So children and adolescents 0 to 19 years of age with fever should be there at least more than 3 days. For Kawasaki disease, the diagnosis for that you need fever more than 5 days, but for MIS-C, fever more than 3 days is enough. So the two of the followings, like most of the features are there in Kawasaki as well. So rash or bilateral non-purulent conjunctivitis, hypotension or shock, and features of myocardial dysfunction, evidence of coagulopathy, and acute gastrointestinal problems. So 2 out of these is sufficient, but even in a child with a diarrheal illness, they might present with hypotension and shock and gastrointestinal problems. So 2 will be sufficient. They are in these children also. So then all of the following should be there in the third component. So elevated markers of inflammation such as ESR, CRP or procalcitonin. And this is the most important tricky statement, that is no other obvious microbial cause of inflammation. So how far we can go to diagnose certain infections at the beginning of the illness? For example, leptospirosis. We may not be able to come to the diagnosis of leptospirosis within first few days of the presentation. So this is the challenge we all have. And then the evidence of COVID-19 antibody, preferably, because the antigen will be negative in most cases. Sometimes they might have positive PCR with a bit of a high CT value, because this is an immunomediated condition. So in our experience, so we have come across lots of children who fix into this diagnostic criteria, but who have got some other illnesses. So these are the classical skin manifestations. You can have any sort of skin manifestation. So in Kawasaki also they mention it as a polymorphous rash. Polymorphous means they can have any form of rash. Maybe an urticarial rash. It may be erythema multiforme like rash. Maybe a scaly rash. So any rash is possible. And the other features of Kawasaki, like conjunctivitis, cracked lips, cervical lymphadenopathy, and peripheral edema. These are the clinical features. So this slide is very important. So there are lots of other disease conditions where they can present features similar to MIS-C, but it is not the case. We had one child with leptospirosis who was managed initially as for Kawasaki disease, the MIS-C, but later on turned out to be leptospirosis, because it took at least 1 week to come to the definitive diagnosis of leptospirosis. And the typhus and Kawasaki disease, we had another child with Kawasaki who had features similar to MIS-C. And then the bacterial infections, toxic shock syndrome, staphylococcal scalded skin syndrome, myocarditis, and serum sickness. So in lots of European guidelines, they have not mentioned about leptospirosis because that is not common there, but that is something which we come across. So the management, I don't think we need to dig into the management, but just I'm going to touch it. So it's mainly mainly depends on how severe, like if cardiac dysfunction, shock, coronary involvement, and multi-organ dysfunction is there. If these features are there, the IV methylprednisolone plus IV immunoglobulin both, according to the guideline, we have to start both. But in the absence of those features, we can manage with either methylprednisolone or intravenous immunoglobulin. In our experience, is most of children ended up in pediatric ICUs. That means most of them had this severe form. Therefore, most of these children ended up in both immunoglobulin and methylprednisolone. And if there's no improvement with that, so there's a place for us to repeat immunoglobulin and high doses of steroids, because at the beginning we used to give low dose steroid, and then aspirin should be continued in an antiplatelet dose. But in Kawasaki disease, at the beginning we give anti-inflammatory dose. So low molecular weight heparin, clotting factor 10A. So these things are other management options. So we need to follow up these children for longer period, similar to children with Kawasaki disease, especially the pediatric cardiology follow-up, while monitoring inflammatory markers, and they should be tapered off with their steroid doses over a period of 2 to 3 weeks. And the last slide. So any child with these days having fever, rash, and GI symptoms, we have to entertain MIS-C as one of our differential diagnoses. However, having said that, we should not miss other common causes like bacterial infections such as staphylococcus, streptococcal, leptospirosis, toxic shock syndromes. And the other important thing is when we get a child to our ward with MIS-C, we need to have a meticulous monitoring of these patients because they can die because of circulatory insufficiency. Therefore, we need to alert intensive care units as well, but all children might not need to go to intensive care units. But if we do thorough monitoring, we will be able to identify those who are needing ICU care. Thank you very much.
Thank you very much, Imaka, for your valuable presentation. Next speaker, I will invite Dr. Bhagya Piyasiri, consultant microbiologist, teaching hospital, Karapitiya. Over to you.
Thank you, Dr. Ganganath, and thank you for the WinCovid program and the pediatric team for inviting me. I'm going to share my screen. So this is not a very hi-fi lecture. This is just to explain some facts and the myths, some of the myths we share with each other. So we all know that COVID is a rampant virus that has redefined the way of our life. So believing in and spreading the myths that surround the virus will only make the fight against the virus much more difficult. So before you share any information about the pandemic, you have to check its authenticity. You have to gather information from the reliable sources and educate those who are around you about the importance of spreading the right information. So symptoms. One myth is that you can identify COVID-19 positives from the crowd. Well, no, you cannot identify always. The virus takes about 14 days for the symptoms to show up, and some people may remain asymptomatic. So everyone needs to follow preventive measures. So what are these preventive measures? Universal masking. There's no question about that. Everybody's wearing masks. And minimum PP in the clinical setup. I mean minimum PP. You have to have the mask, face shield or goggle, overall, plus gloves. Plus hand hygiene, very important. And extra protection in aerosol generating procedures. Right? You have to have a N95, okay, N95. You have to avoid congestion in your rooms. And no meals or tea together, no sharing at all. We had that privilege before, and we are going to have that privilege in the near future. Maybe, we don't know. But at the moment, no sharing, no dining together, no, nothing. Not even Kottamali sharing, right? So there's another myth that you have to have double surgical mask or double N95 or KN95. No evidence. Actually, it hinders your breathing, unnecessary and waste of resources. But in our clinical setup, we have advised to wear 2 masks. That's true. One N95 over your face and a tie-on surgical mask over the N95. There's no any other way of wearing 2 masks. Surgical mask will provide coverage against possible spillage on your face due to fluid-resistant layer. And also, the additional advantage is, if you are running out of resources, we might be able to use and reuse N95 with the protection under the surgical mask. So this is how you wear 2 masks, N95 first and the tie-on surgical mask over that. Gloves. The myth is you should wear 2 or more pairs of gloves always. Well, no need. Maximum 2 pairs. Inner pair to be worn continuously inside patient area until the end of the round, and outer pair to be changed between patients to prevent cross-contamination, especially in the HDU ICU setup. A slight deviation from the main topic, Ebola versus Corona. What you know about Ebola and what you know about Corona, right? The myth is you cannot see a positive patient without all the items of the standard full PP, which is the Ebola kit actually. The fact is, the Corona kit needs mask, preferably N95, eye protection, overall, fluid-resistant apron and gloves. That's it. And shoe cover, plus or minus shoe covers and cap. Additional suits, head covers, boots are optional. If you have, you wear. If you don't have, don't bother. So one major difference between Ebola and Corona is the modern timing of transmission. That's why these suits are designed. Ebola is spread during the last stage of the disease through body fluids, including the blood and sweat. One breach of your skin will render you very vulnerable to catch the disease. That's why you need to cover from head to toe with the PPE kit. But corona, we know what the mode of transmission, and you need to protect the face area, the eyes, nose, and your mouth. Right? So this is the graph you are familiar with. You can see the top graph, the virus, the pre-symptomatic and the symptomatic period, the virus load goes up, but with time, by 8 or 10 days, it comes down very nicely. But Ebola, in the ICU setup, is the most contagious people are, because with time, the viral load goes up. Influenza, the same. Another graph. So this shows in the mild disease, by day 10, you have unviable viral culture. And even though in the most severe disease, by day 20, you have zero virus. Hand hygiene. I told you, with PP, even with the full PP, you need to have your hand hygiene. There's no any other excuse. You have to follow the 5 moments of hand hygiene, and you have to follow the correct steps of hand hygiene technique. One myth is that hand hygiene with 70% alcohol over the gloves is beneficial in between patients. Well, if you are 100% sure that your gloves are not containing any organic matter, secretions, excretions, then you can have your sanitizing in between patients over the gloves. But if the gloves contain secretions, organic matter, alcohol gets neutralized. So no killing effect. Cross-contamination occurs, causing high mortality and morbidity. Healthcare workers' safety is also not assured. So the best way is to remove your outer layer of gloves in between patients. Another myth is hand washing with water only is also beneficial. Well, no, actually, soap is essential for an effective hand washing, as soaps or detergents dissolve fatty materials along with germs and facilitate their subsequent flushing with water. So even baby soap will do the job, right? You don't have to have very high-fi antiseptic soaps. Another myth is healthcare workers should remain in isolation at home during the duty period in the COVID wards or units. Well, no need. If the healthcare worker, no need to self-isolate. All healthcare workers should adhere to the guidelines on PP and other protective measures issued by the COVID team and THK. So we have issued the guidelines, we have issued all the protective measures, the protocols, so you have to follow those things. This is another kind of a draft on donning PP and doffing of PP. Donning PP, there's no any guideline in the world which describes the PP we used to wear, right? The full PP, the so-called full PP coming from MSD. So this is the in-house protocol we have prepared in Karapitiya for you to teach on donning and doffing. One important thing I have to highlight is that wearing N95 or N95 mask. Some people are coming from with N95 or KN95 from at home, or they wear a new one when they are in the hospital, and when they are going inside the patient area, the PP kit is also having N95. What they do is they wear the additional kit PP, the N95, over their already existing N95. I don't know, you will be suffocating, right? So no need. So you have to keep you have to keep on your new the already wear the one N95 over your face because it's new, and you can keep the N95 coming with the PP kit for future use. And the wearing surgical hood. If your rabbit kit is having a surgical hood, right, head cover, no need to wear additional head hoods. So it's a hazard to you, actually. So if you're having a surgical hood with your rabbit kit, that's enough. And with doffing, the doffing is very, very important. Doffing after each and every step, you have to wash your hands. That's why the sanitize your hands. That's why this list is very long. And the one thing is, we have advised you to wear 2 masks, one N95 and surgical mask on top of that. When you are removing your PPE, you have to make sure that you are not self-contaminating. That is the most important. And you have to leave the doffing area with your N95 on, right? You remove only the surgical mask and you are leaving the doffing area with your N95 on, and you are going for the shower or bath, and then only you remove your N95. So this is the simplified donning and doffing instructions given by CDC. This is the corona kit, not the Ebola kit. Another myth is all COVID deaths are due to COVID itself. Well, not at all. Many COVID deaths are dying. COVID patients are dying due to sepsis following nosocomial infections like a catheter-related bloodstream infection, ventilator-associated pneumonia, catheter-associated UTI, blah, 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 all sorts of infections due to the immunosuppression rendered with drugs, steroids, sacituzumab, likewise, or the infection itself, the ICU and the lines and catheters in the ICU setting, all that contributes to render their secondary infections. This is the analysis of our positive blood cultures from May to 31st August. The total number of 85, you can see 19 of them had catheter-associated bloodstream infections, that is 22.35%. Except one, all other died. Right? This is a very pathetic situation. That's why you need to have your all protective measures not to give nosocomial infections to the patients. Right, the last slide. So you need to protect yourself and also the critical ill patients from nosocomial infections. Infection prevention and control measures should be followed up with handling patients, and also hand hygiene and aseptic procedures are of utmost importance. We can win COVID together as a team where you all are key members of that team. Thank you. The end. Thank you very much.
So, nice presentation. For next speaker, I'll invite Dr. Harshini Piyasiri.
What is the staff foundation of this staff?
Thank you very much. Next speaker, Dr. Harshini Piyasiri, consultant psychiatrist.
Good morning. It's me, Dr. Gayani Punchihewa, who is supposed to do the
Sorry about that.
lecture. That's okay. Yeah, I'll see whether I can share the screen. You can hear me well, huh? Can you hear me?
Yeah, we can hear me.
Okay. Right. Okay. Good morning to you all. Now you all have been listening to the lectures today, how best you can provide care to your patients, right? So how to make you more competent and how to be more confident, and then how you can protect yourself and how you can be safe. So all those information you have gathered up to now. Right? So we know we are in a very unique situation, deadly pandemic, and things are very different. So even if you have all these, if you're armed with all these information and skills and confidence, you need your stability psychological wise. Otherwise, it would be very difficult for you to cope with the situation. So I'm supposed to talk about psychological well-being of you all during this pandemic, how well you can balance your work life and personal life, family life. Those things we will discuss. Right? Okay. Sorry. So I would mainly focus on your how you can keep the balance, psychological well-being, while you are delivering your best care to the your patients. Now, mainly you will be dealing with the children, so the circumstances would be a bit different to that of dealing with the adults. So because you are dealing with these youngsters, small children, you may be having additional stress, but I know you all are experienced with dealing with the children, so that will make you more confident, right? So we will have a look at what are the problems that you might encounter. Right? So they talk about 3-level model of mental health considerations for healthcare providers. Now this slide has kind of summarized it. Now you all have been through these stages to some extent, not all, right? Especially the early exposure where you have anxiety, fear, because now in the early part of the exposure, and now we have been in this pandemic for about nearly 1.5 years now. So you all remember at the very beginning, we were very worried about our main concerns were being quarantined, because we were sent to specific centers, but now things have changed. Now, if you are quarantined, so it's you can quarantine at your own place, self-quarantine, but now the fears have changed. Now it's contacting the illness, right? So apart from that, now other main worries whether you would take this home, right? So you are worried about your loved ones, your family. If you have elderly parents and you are worried with that, so you have a lot of anxiety, as Dr. Bhagya mentioned during her talk, right? That you need not to isolate yourself when you are at home if you have adhered to proper protective measures. But still, I know you feel anxious because you are worried and you love your family members, right? So at times you can feel guilty about it, right? So you may not be able to interact with them, especially with children or your parents, as you used to be. You try to kind of distance from them, even if you're at the same place, right? So that might lead to feeling guilt about, because of me, they have to suffer. So you have to identify these feelings as well. Then when you are working with the patients also, the workload will be additional stress to you. Now you will be rostered maybe more frequently than before, and sometimes I have heard this over and over again. Sometimes you get to know that you are allocated to the COVID ward just before the night before, the day before. So those cause increased anxiety because you don't have time to plan your week, get additional support or help arranged. And then once you start working, as I told you, that you'll be working with the children, so their presentations and their requirements would be different, and sometimes you may be you might feel helpless because you may not be having enough assistance, enough maybe healthcare facilities, so that will make you to feel helpless and hopeless. And other thing is this ambiguity. The things are changing now. You know, at the very beginning of the pandemic, I mean, we thought the children were safe, but now things are changing. So with the changing situation also, because you don't know what will happen next, that also will lead to make you feel anxious. And then, as Dr. Bhagya mentioned, there may be shortage of protective equipment and difficulty in using them. So we have to make an additional effort to get these things. And then at times, I mean, you do your best to deliver the care, but ultimately, patient loses his or her life, and then sometimes you feel all my efforts have been futile. So you feel that can lead to you feeling depressed as well, and that you feel that you don't have control over the situation. So all these things, you will, all these emotional kind of a roller coaster, you will go through this. Sometimes few of the healthcare providers can go into depression, post-traumatic stress disorder, or burnout as well. Right. So how are you going to cope with these changes in emotions, right? So one thing is stay informed, right? So now, like the programs like this will give you correct information, because there is kind of information overload. We get a lot of information, incorrect information from social media, various other sources. So you make sure that you get correct information, scientific information, so that will make you more confident and competent. So always try to have access to genuine, authentic information from which have scientific basis. So you can, if you have any doubts, you can get it clarified from your colleagues or seniors, right? And at the same time, so you have to avoid information overload as well. And unnecessary information, just make sure that you avoid. If you browse in social media, if you spend a lot of time in social media, there will be a lot of negative information that would kind of reduce your enthusiasm, that reduce your willingness to help. Sometimes, especially this health frontline healthcare workers get criticized, but I mean, that might discourage you. But I mean, we should not get into that situation. So make sure you avoid this negative information. And the other important thing is staying connected with your loved ones, friends, even though you may not be able to physically get connected, but we have all these communication platforms where we can use mobile phones or any other communication platforms to stay connected with your family members. I know some doctors, they don't even visit their parents because they are scared that they might get the disease from you all. But talk to them, right? You can talk to them, get a video call and talk to them and talk to your friends, but make sure that you stay away from negative people who would make a negative impact on you, right? So it is very important staying connected. And the other most important thing is maintaining healthy lifestyle, right? So physical, look after your physical health. So eat well, sleep is very important, sleep well, and have a balanced diet. And if you have time, have some time for exercise, physical exercise, all these things. I know it's busy and it's for easy for me to say this, but for you all, it may be difficult to find time. But if you identify your priorities and if you manage your time properly, you would be able to engage in these activities. Make sure you stay away from alcohol and smoking. So these are maladaptive coping strategies. When you are stressed up, you might turn to these coping strategies, but always remember, so engaging in your leisure activities. I mean, each one of us have diverse interests, music, writing, reading, books, these things, which suits you. So find time to engage in those activities just to make you feel relaxed, right? So you can practice, engage in religious activities, meditation, relaxation, yoga. If I know there are doctors who engage in these activities, so you can continue to do those things, although you are not able to go outside, like going to a gym or to practice yoga to other places, but you can do these things at home. And then you need to know your limits. I mean, you may be a very committed, dedicated doctor, so you want to do your best, but you have to know your limits. We all have our limits. So if you go beyond your limits, that will make you will break down, right? So if you have to have rest, so you discuss with your colleagues, and if you feel that you are overwhelmed, you are exhausted, that you feel that you can't go on like this, get help. So talk to your colleagues, talk to your seniors, try to arrange your rosters or whatever duty schedules to make you able to have a break. And identify your priorities, right? This is also most important, because if your health is compromised, then you won't be able to help others, right? So you will need to identify the point when you would need professional help with regard to your psychological state. That is also important to know when to seek professional help, and don't hesitate to seek help if you feel like. And if any one of your colleagues or your seniors advise you that now, look here, you need to go and speak to somebody, a professional, then don't hesitate, right? So we have a lot of resources, right? Okay. Now, Sri Lanka College of Psychiatrists, if you visit the website, there are a lot of resources and there are videos. So I have put a link here that how you can cope with stress. And in addition, there is this 1926 helpline, which is run by National Institute of Mental Health, a 24-hour service, which is manned by trained staff, nursing staff, and consultant psychiatrists. So if you don't feel like getting help from a psychiatrist or psychologist in the area where you are working, so you can get help from this helpline. So you are lucky. We have 4 psychiatrists in the University Psychiatry Unit, and then 4 psychiatrists in the Health Ministry Unit, and there's special child psychiatrist as well. So if you have any issues regarding your children or children you are managing, so you can reach I think introduction, Dr. Name was mentioned, Dr. Darshini Hettiarachchi is the child psychiatrist, and even in the university unit, we have Professor Chandani Hevage, who is a child psychiatrist. So you can always get help from us. We are more than willing to help you all. That's all I have to say. I'm happy to answer any questions if you have any. Yeah, this is just to make you confident that I have taken a quote from one of the doctors who is working in a primary health care center in Bangladesh, just to keep you motivated. If you have any questions, I'm happy to answer.
Thank you very much, Dr. Gayani Punchihewa, for valuable time and valuable lecture. Thank you very much from in the behalf of pediatric team at Teaching Hospital Karapitiya. Thank you very much again.
You're welcome.
Next, we'll move on to case presentation. Then I like to invite case presentation from registrars, Dr. Hasini Makwella and Dr. Sevgandhi, Dr. Vimalaguna and Dr. Veerasinghe will do case presentations. We'll ask them to start case presentation now. And again, the discussion, me for myself and Dr. Raghunathan, pediatric cardiologist, is here with me. Yeah. To share the screen.
Morning, everyone.
Please start. Yes, still you can't see.
Case presentation 1 is regarding.
Just wait. Still, video. Still, your screen is sharing. We can't. Yeah. Yeah. Presentation. Make a presentation mode from this PowerPoint. Make it as presentation mode. So double click it, then it will make a presentation mode. Just double click. On the side, you just double click.
Good morning.
Start. Yeah.
I'm Dr. Sevandi. This is the case one. This is 1-year-old baby girl, previously well child, presented with fever and runny nose. Mother's and baby's rapid antigen test was positive. On examination, there was a fever documented as 100 Fahrenheit. Child was well and active. Hydrogen was good, hemodynamically stable, and lungs clear. We did basic investigation, full blood count, and CRP, which were normal.
Yeah. How did you manage this child?
This child is mildly symptomatic, but as child is less than 2 years, we can't send this child home. So we have sent this child to the intermediate care center.
Yeah, that's the key. That here it is age is less than 2 years. Then we have to we can't but child is mildly symptomatic. Therefore we can but we have to observe because of this guidelines. Therefore we have to send this child to intermediate care center. Yeah. Thank you.
Yes, sir.
Yeah, you can share your screen.
So give us a minute.
Yeah, you can start.
Good morning.
Yeah.
Can you hear me?
Yeah.
This is case scenario number 2. This child is 8 years old boy who was found COVID-19 red positive at OPD level. This child is previously well, but the child is having a higher BMI. On admission, there's no history of fever or respiratory symptoms, and mother is having mild cough and fever. As mother is having symptoms done at OPD, at that time, both mother and child were positive. As the child is having a mild faintishness after the rat, child is admitted to ward 68. On admission to ward 68, child was afebrile, but the child is obese and BMI around more than 25. And saturation was normal and blood pressure also normal. So we have sent basic investigations, count and CRP, both of them were normal. And at ward 68, we have a child only managed with close observation, no any treatment given. And the question is, at last, do we have to discharge this patient for home-based care, or do we have to transfer the patient to intermediate care center? The answer is, as the child is, although child is asymptomatic, but the child is having comorbidities like obesity, we have to send the child to intermediate care center. And the message is, although child, any child with child with less symptoms or asymptomatic state, but the child is having comorbidities like obesity and chronic lung disease or the congenital heart disease, we have to care and observe the patient in intermediate care centers. Thank you.
Thank you very much. That is the key, that here actually child is more than 2 years, but child is mildly symptomatic or asymptomatic. Then we can actually those children we can send home, and we can regular follow up telephonic conversation, and we can follow up them. But here, of course, there is a patient with a comorbid disease. Either it could be something like this obesity, it could be a chronic lung disease, chronic renal problem, or something like that, or cardiac disease. Then we can't send them home. Then we have to give care at our intermediate center. Then we have to transfer this child to Melbourne. Yeah. Next speaker. Yeah, we can see that. We can see it.
Ashini is doing that. Very clear. So unmute.
We can see. Yeah. Yeah, we can see you. Yeah, please start.
Why are they waiting?
Yeah, please start. Yeah. Yeah, you can start the presentation. We can see your screen. Yeah, Dr. Asanki, you can start presentation.
Hello, everyone. I'm Dr. Veera Singh. I'm going to discuss a case scenario who's a child who's more than 2-year-old who is symptomatic with COVID infection, and we have managed the child as presumed sepsis.
Down key. Just double click it on it. Then
He's a 5-year-old baby girl who was previously well, presented with fever for 8 days duration, with vomiting, drowsiness, and generalized tonic-clonic convulsion, which was developed on day 8 of illness. But the child did not have any respiratory symptoms or other urinary, GI, or musculoskeletal symptoms. And the child was seen at private sector by a pediatrician and pre-treated with oral azithromycin, which was given for 1 day. Then on admission itself, the child developed the convulsion. So at the ETU, child's parameters were pulse rate is 150 with capillary refilling time less than 2 seconds. Saturation was maintained on air with 98%. However, child was started on 5 liters oxygen via face mask, and CBS at that time was normal. VBG was sent, which was showing metabolic acidosis, and with a lactate of 5, which required IV normal saline 10 ml per kg bolus, followed by a maintenance drip. And in view of convulsions, they have started IV midazolam. And also with the presumed sepsis, they have started IV ceftriaxone as well. Later on, the investigations revealed presence of WBC of 8,000 with CRP 9, which was in rising trend. That was 34 with the repeat CRP count. And also blood picture was showing bacterial infection. However, so with that, we proceeded. And also child also had drowsiness as well. With that, we proceeded to do a LP, which was normal. So the child was received level 2 care at Ward 36, and we continued IV fluids and also IV antibiotics. And later on, we omitted oxygen, and close monitoring of the vital parameters was continued. So that's how we managed a child. Thank you.
Thank you. Thank you very much. Actually, this child again. A patient who is having symptoms, then we have to admit this child and give him inward care. Then here Dr. with us, madam. Just.
No, it's symptoms, but not COVID symptoms, yes. Right? So that anyway, we have to monitor this baby and observe closely. So that's why we send this baby to Ward 36.
Yeah, that's then we will get patients with not with the COVID symptoms, but with the other symptoms as well, but COVID positivity. Then at that time, we have to manage the relevant medical condition with the precautions. But we have to give all the care, but all the management as in other patients. We have to make sure that we are giving precautions, and we have to separate them from the other patient and manage it. That's how we have done it, and because key here, we have to identify the other comorbid factors. We have to manage those things at the same time with the monitoring for COVID as well.
We'll go for the
next. Dr. Hashini will start next one.
Good evening. And for the fourth case scenario, we are going to discuss about multi-system inflammatory syndrome in children. A 7-year-old boy from Neluga without any past comorbidities presented with acute onset high-grade intermittent fever, which associated with headache, irritability, vomiting, abdominal pain, loose stools for 4 days duration. No respiratory symptoms or urinary symptoms other than reduction in urine output. No contact history of fever, respiratory symptoms of COVID-19 infection. No recent history of respiratory symptoms of fever or COVID-19 infection. Admitted to base hospital Udugama and transferred to PICU Karapitiya due to circulatory insufficiency. On examination, child had bilateral lymphadenopathy, limbo-sparing conjunctivitis, and mucocutaneous inflammation. And cardiovascular examination, child was tachycardic and hypotensive. And respiratory examination, there were bilateral pleural effusion and saturation maintained at 97% with 5 liter oxygen. Abdominal examination, abdomen was distended, generalized tenderness was there, no organomegaly, no renal angle tenderness, there was a horseshoe dullness. CNS examination was normal with normal GCS, no signs of meningism, cerebellar, cranial nerve examination and motor examination was normal. Investigations, child was little anemic, HB 9.1 and thrombocytopenia was there, platelet 61,000 and INR 1.63, little bit elevated, CRP 236, ESR 105, elevated inflammatory markers, and there was hyponatremia, sodium was 131, renal functions were normal, UPCR was normal. Liver functions within upper normal level, there was hypoalbuminemia of albumin 25, protein within normal range, and serum amylase also normal. VPG, there's no acidosis. Blood culture, urine culture, there was no growth. SAT was done to exclude typhoid, it was negative. COVID PCR and RAT both negative, and COVID antibodies later on came as positive. Initial ultrasound abdomen, there was mesenteric lymphadenitis and periparetic ileus. Second ultrasound scan done at Karapitiya Hospital, both kidneys slightly echogenic with preserved corticomedullary demarcation, no sonographic evidence of appendicitis, and there was mesenteric adenitis and scrotal wall edema. ECG, there was no abnormality other than sinus tachycardia, 2D echo, dilated coronaries, left main coronary artery diameter was 3.6, LAD diameter 3.9, right coronary artery diameter 4 millimeters, no pericardial effusions. Ejection fraction was 55% and mild left ventricular failure was noted, and tropi also elevated. In our child, we have diagnosed multi-system inflammatory syndrome of childhood because child had more than a fever for more than 3 days and elevated inflammatory markers, negative blood and urine cultures, and positive COVID antibodies plus mucocutaneous inflammation, conjunctivitis and mucosal inflammation, and gastrointestinal manifestations such as mesenteric adenitis, vomiting, ileus, and cardiac involvement, elevated tropi, coronary dilatation, and child was in shock initially, and evidence of coagulopathy, elevated INR. Initially, we had to give normal saline boluses and inotrope support because of circulatory insufficiency, and inotrope support needed for 3 days. And specific management, we have given IVIG 2 gram per kg, and we had to repeat after 48 hours because of poor response, and started on aspirin 50 milligram per kg and convert to 5 milligram per kg after afebrile 72 hours. And initially, to cover sepsis, we have given IV meropenem, metronidazole, doxycycline, and azithromycin for 10 days duration. And supportive and symptomatic management, you can omeprazole, famotidine, domperidone, and potassium supplements. And follow-up, 2D echo done in 2 weeks duration. After 2 weeks, there was left main coronary artery was 3.6. It's a little bit increased, and LAD is 3.8, and there was a fusiform dilatation noted in LAD, and right coronary artery diameter was 3 millimeters. And after 3 months, those dilated coronaries were sizes were reduced. Left main coronary artery diameter was 3 millimeters, and LAD 2.6 millimeters, fusiform dilatation noted, and right coronary artery diameter was 2.8 millimeters. We have continued aspirin 75 milligram daily and plan for next echo after 1 year. After 1 year. Thank you.
Yeah, so this one, what category you will be? I think we had to classify this as a severe form of MIS-C because child has presented with shock. The problem, I think we have not given methylprednisolone here. I think Hashini asked me before. So the reason was when he was managed in the PICU, we haven't got the antibody results, and parents were negative or like no histories at the beginning. So we were in a dilemma whether to give methylprednisolone or not. So at that moment, our working diagnosis was Kawasaki alone, not with the COVID at that presentation, because we were at the initial stages of getting a surge of MIS-Cs. Nowadays, they say there is a contact history you can think about. I think the Ward 2 one also, the one we sent to LRH with obese patient, we didn't have the contact history. The antibodies became positive after going to LRH. But anyway, we suspected and start treating as MIS-C with the shock. So methylprednisolone we haven't given, but in spite of that, we have given a high dose aspirin here. So that would have benefited. And immunoglobulin, we have given 2 doses. And that probably because of the dilated coronaries, that is the reason I think the coronaries have come down to normal sizes in the subsequent echoes. So the problem with the MIS-C would be, because we are all going by the investigations. And unless we see echo finding dilated coronaries, we can't 100% see whether it's a MIS-C or Kawasaki. We had to go by the other criteria. The problem is getting the antibody levels. We get a little bit late. But nowadays, I think we know that taking the risk and give methylprednisolone early will be helpful.
Like in our patient who had very high creatinine level, like 500.
Treated as leptospirosis.
Whether this is leptospirosis as well, because that had the bilateral effusion.
But when you see the echo with dilated coronaries, poor LV function, I think at this current setup, this is MIS-C other than anything else.
We are suspect MIS-C with lower. So
and the other aspect is there was another baby with COVID status positive. We treated as COVID MIS-C, dilated coronaries, but turned out to be a atypical Kawasaki with progressively dilating coronaries. So we will have all kind of dilemmas, diagnostic dilemmas nowadays, but the management, I think we will be covering with either high dose aspirin or methylprednisolone, which will anyway manage the acute problem.
Here the main message is we have to suspect MIS-C at early stage. Then very good suspicion that we can catch this disease, because we have to start treatment early, especially in moderate and severe cases, that Kawasaki. Then severe patients, we have to start suspecting these patients, and we have to catch them early. That is the key here, and start early management again the key. That is because that now because it's children are exposed to COVID, more and more exposure, and now within next couple of months, within the next month or this September and October, we will get more and more COVID and more and more MIS-C patients. More than COVID, we will get the MIS-C patient in pediatric practice. We have to make sure that we are detecting them early. And other thing is that Dr. Imalka mentioned in his lecture that there are other diseases. They are mimicking MIS-C like picture. Then we have to think about those things as well. Then we come to end of our program. Actually, I will start to make closing remarks. First of all, I would like to thank Dr. Ganaka Senaratne. Actually, he's having the brand of WinCovid, and then giving his this thing and his with this conception, and this is very good, and we'll give our first thank you to Dr. Ganaka Senaratne, then to the GMA, actually Professor Samath Gunawardena and GMA staff. they have given a lot of courage and a lot of their facility, and as well as the managing staff. They give a lot of courage and a lot of support to us, and still they are with us with this program. And next, I would like to thank Dr. Prageeth Asanka, then, because he asking us several times to encourage us to do this thing, and because of that, I would like to coordinate with a lot of doctors, and I will give thanks to him as well. Then Dr. Nalin Kitulwatta, consultant in intensive from Ledbridge Hospital. He all the way from Ledbridge Hospital. He joined and give us give us a lecture and his experience. Thank you, sir. And thank you to Dr. Nalin Kitulwatta. Then Dr. Bhagya Piyasiri, consultant microbiologist from Teaching Hospital Karapitiya. He gave us his impression on a lot of myths and facts about this COVID and PPEs and all. And then Dr. Gayani Punchihewa, consultant psychiatrist, and she joined us and gave a very valuable inputs regarding this COVID and our psychological aspect. Then you all, all the participants, will thank you, because without you we can't do this one. And last, I would like to my team, then pediatric team, Teaching Hospital Karapitiya from Dr. Aruna, who initiate this process, and then gave all the support from from Dr. Pekshali and Dr. Emal Silla, and as well as from university unit, Dr. Imalka and all the seniors from unit, and as well as other Dr. Raghunathan and Dr. Parami and everybody from pediatric team. I would like to give big thank you. Thank you all. We'll join you in future. Thank you very much.